Our next paper will be Surgical Management of Duodenal Perforations After ERCP, the Crucial Role of a Retroperitoneal Approach, by Dr. Sergio Alfieri and his colleagues from the Department of Digestive Surgery, Catholic University, Gemelli Hospital. Dr. Alfieri. Is Dr. Alfieri here? Okay, would anybody else like to give Dr. Alfieri's paper? Okay. Well then, we'll go on to the next paper. Partially covered esophageal stents cause bowel injury when used to treat complications of bariatric surgery, by Drs. Wei from the Division of General Surgery, University of Missouri in Columbia.
Well, thanks, Dr. Green. Thanks, Dr. Stickman. Thanks for the Society for providing this opportunity for me to present our recent research. So I'm presenting the partially, do you have excuse me, do you have slides I can take a look? No slides? Excuse me, do you have slides I can? Okay, sure. Yeah, okay, thanks. So I'm presenting partially covered esophageal stents cause bowel injury when used to treat complications of bariatric surgery. I'm currently a surgical resident from University of Missouri. No conflicts of interest to disclose. Study background. Gastrojejunal anastomotic leak or stricture occurs in 1 to 5% of patients after Roux-en-Y gastric bypass. Traditional surgical treatment is technically challenging, carries a high morbidity and mortality. Emerging off-label usage of removable esophageal stents showed favorable short-term results in treating the gastrojejunal anastomotic complications. However, the fully covered stents carries high stent migration up to 58% in our recent study, which limits its clinical application. Our hypothesis is a stent that is mainly silicone covered but has a portion uncovered may allow tissue ingrowth and decrease the migration rate. Our study design, this is a retrospective study of a year. 8 patients received uncovered stent. We used off-label esophageal stent to treat patients with the gastrojejunal stricture, leak, or leak followed by later stricture, and perforated gastrojejunal ulcer. As you can see the cartoon on the left side, endoscopy-directed guide wire passed through the gastrojejunal leak site to the distal ruling. The paper clips were placed at skin level with the fluoroscopic guidance to help identify the gastrojejunal and the gastroesophageal junction, and stent was the appropriate position and started deploying. At the end of the stent deployment, the stent, of course, covered the gastrojejunal leak site with the proximal end of stent at the distal esophagus. Upper GI counter study was performed the day after, and oral nutrition was initiated after confirmation no leak or blockage, and stent was generally removed at the 4 weeks. We have 8 patients received the study, 5 male, 3 females, age averages from 38 to 51 years old. Our initial response, as you can see, 3 patients with stricture each received 1 stent treatment. 1 patient with stricture received 3 sessions of stent treatment. 2 patients with the leak each received 1 stent treatment. 1 patient with the leak and stricture received 2 sessions of the treatment. 1 patient with the perforated ulcer received 4 sessions of a stent treatment. Except the patient with the perforated ulcer, all other patients had a 100% symptomatic improvement and 100% oral nutrition initiation within 48 hours. Overall, we have 86% symptomatic improvement and 71% early oral nutrition initiation. We observed complications. 71% stent present with mild displacement of the proximal end of stent from the distal esophagus to the stomach, at the time of stent removal. However, the site of pathology has been well covered, and we didn't observe any stent migration in our study. Major tissue ingrowth, which embedded to the mucosa, has been observed in the proximal uncovered portion of the stent. Two happen in the esophagus, which required laparoscopic enterotomy, and 2 sessions of endoscopy for removal. One patient with proximal end stayed in the stomach at the time of stent removal required prolonged extraction time. Location of the proximal end of the stent and the bowel mucosa injury. As you can see, 4 out of 4 stents with the proximal end of stent stayed in the esophagus at the time of stent removal present mucosa injury, either ulceration or granulating tissue replacing the normal mucosa. 7 out of 10 stents with the proximal end of the stent stay in the stomach present mucosal injury. Conclusion, a partially covered stent which was proved successfully in keeping the site of pathology covered in all patients, although the displacement of the proximal portion of stent from the esophagus to the stomach was seen in most patients. A partially covered stent provides rapid symptom improvement and oral nutrition in most patients. The uncovered proximal portion of stent may cause significant bowel mucosal injury. The uncovered proximal portion of the stent sometimes becomes embedded in the esophagus or the stomach, making a removal difficult. Removal of the partially covered stent may be difficult and risky when treating gastrojejunal and anastomotic leak complication of the Roux-en-Y gastric bypass.
Thank you very much. I think this will be some discussion for this paper. Dr. Marks?
Sure. That was a very nice presentation. And you're bringing up an excellent point that we're all facing when it comes to management of our complications of putting metal things inside the GI tract. It's not a perfect science. When you selected this type of stent, was it because you wanted to try to prevent the complications of migration rather than selecting a fully covered stent?
That's correct, yeah.
Okay.
So the study before this, we used full covered stent, end up 58% stents migrate distally, requiring endoscopic, removal and restenting, yeah.
Right, so 2 suggestions. Again, maybe the problem is until we come up with a better stent system, they probably do need to be fixated externally, whether it be by sutures to the nose or something. And the other thing is, if you do have your stents in growth, how did you get them out? Because we've also had some situations where I've had to take other physicians' partially covered stents, and what we do is we put another fully covered stent inside that and then bring them back after about 5 or 6 days, and it usually kills the granulation tissue.
Yeah, that's a great way to go, but I don't know how much cost to go that way. But we just thinking in our study, the tissue ingrowth is severe, requiring very aggressive removal and cause more injury, yeah. So we stopped using that.
Next question, please. Thank you.
Brian Davis, El Paso, Texas. I'd like to compliment your group's innovation to certainly tackle this difficult complication group. Are you looking at any kind of Vicryl type absorbable clips or T-faster devices that could be used to temporarily fixate the stents into the esophagus?
We haven't.
Thanks.
Thank you.
Other questions, comments? No tweets from here?
No tweets.
Thank you very much.